Thank you, Jordan. For those of you who don't know me, I am currently the president of the World Hepatitis Alliance, which is a patient-led and patient-driven organization based in London with almost 300 member groups, patient advocate groups in more than 90 countries, really working to get the voice of the patient involved in every step of the viral hepatitis response. I'm also, importantly, a former hepatitis C patient. I was diagnosed in 1990 when almost nothing was known about hepatitis C having only been cloned and named the year before. When I was diagnosed, I asked, so what does that mean? I hadn't heard of hepatitis C. Most people hadn't. Many in the medical community had not. And I was told not to worry about it. And I didn't worry about it for about 10 years until I started to show signs of liver disease, and I was fortunate enough to get into a clinical trial for telaprevir, one of the first DAs that was approved in 2011, and I see some knowing smiles and nods. I would not wish that on anyone, but it did do the job. I was cured, and not only was I cured, at the time of treatment, I was cirrhotic by FibroScan, well above 20 kPa, and that was in 2009. Since then, I have had serial FibroScans every 2 years or so, and just 2 weeks ago in Boston, for the first time, I have a FibroScan that is within the normal range. So I have seen a continual regression. Yeah, it's very exciting. It's very encouraging for people who are living with viral hepatitis who have liver disease, and it really illustrates the importance of treating as early as possible. So today I'm going to talk about the importance of the patient voice in the viral hepatitis response. A very, I would say, important announcement that just happened at the liver meeting in Boston a few weeks ago, where all of the liver disease associations, the major ones, committed to the elimination of viral hepatitis, specifically hepatitis C. And then in the US, I'm based in Seattle, where I run an NGO that does work primarily with underserved and marginalized populations. We work with people who use drugs, we work with people who are marginally housed. We run a network of clinicians and researchers and community-based groups who work on hepatitis in prisons and jails. And we also are the first state to have an elimination plan for hepatitis C in the US. And for those of you who don't know, the US really functions as far as healthcare delivery as 50 different countries, 50 different health systems. And so it was a big deal for us to get that commitment from our governor to create an elimination plan for hepatitis C, and I'll be finishing up talking about that. So Jordan very eloquently pointed out the calculus around hepatitis C. Very simple: test, treat, cure. We have the diagnostics, we have the treatment, a pill a day for 8 weeks. It could not be simpler. But why do we have 90% of those living with hepatitis C globally undiagnosed? We can't get to elimination without involving those who are affected by viral hepatitis, especially when we're talking about vulnerable and marginalized populations. People who use drugs, people who are homeless, people who are in prison and jail. We need to work with these communities to get to the people who are at risk and to bring the testing and treatment to them. So at the organization that I run in Seattle, the Hepatitis Education Project, we are starting to do that, and we've been doing it actually for quite a long time. Originally, a support group started in 1993. We have, over the years, expanded the direct services that we do. 10 years ago, we started testing for hepatitis C. With dried blood spot, we had to send the specimen back to a lab in Chicago, and by the time we got the results back, usually 3 or 4 weeks later, half of our clients were already in the wind, lost to follow-up. We have seen the advances in rapid diagnostics. We still don't have access to GeneXpert in the US, which is an issue, but in our office in Seattle, we will do the rapid tests, and for those who test positive, we will immediately do a blood draw. And a staff of almost 20, about half of them are trained as phlebotomists, and we have a very good continuation rate for those who test positive for antibodies, get that RNA test, and then we have a full case management team, which very importantly includes peers. So people who are living with hepatitis C, people who are on Medicaid-assisted therapy, as part of that case management team, bringing them through care and treatment and eventually to cure. This cannot be overstated, the importance of addressing stigma. It is a huge barrier for a lot of people, and it plays out differently in different parts of the world. In some parts of the world, just having a hepatitis C antibody test is grounds for being allowed from certain kinds of work. Hepatitis B is a huge stigmatized condition in much of Asia. My wife happens to be from China. She likely contracted hepatitis B at birth. She did not know she had hepatitis C until we met in graduate school. I knew the prevalence of hepatitis B in that part of the region. I asked her if she'd ever been tested. She said no, and sure enough, it turned out that she does have hepatitis B. Inactive, fortunately, but when she found out, she said she was so grateful that she learned about it in the US and not in China, where it would have likely affected where she ended up going to school and possibly the ability to even emigrate to the US. I was very pleased to see and be part of this declaration that was signed by 4 major liver disease associations. As I mentioned just a few weeks ago in Boston, John Ward was involved as well. And it was, I think, an overdue call. The specialist liver disease associations have really not been at the forefront of the elimination efforts, and coming together with the support of the Clinton Health Access Initiative, who played a pivotal role in drafting this declaration. And again, I'll point out that this was just for hepatitis C. There were 4 clear points to this call to action: simplification, integration, decentralization, and task sharing. And to have the specialists sign off on these ideas, especially decentralization and task sharing, was really no small feat. As those of you who know, and again, it plays out differently in different parts of the world, specialists and liver disease specialists, GI docs, hepatologists are certainly no exception, are often very reluctant to let go of what they see as their rightful place in the healthcare delivery system. That despite the case that in much of the world, certainly in the US, GI docs and hepatologists don't even treat hepatitis C that much. And it's this interesting kind of tension between protecting and really not doing the work. So this was a huge statement that all of the 4, so US, Europe, Latin America, and Asia signed off on. And I'll just go through them very briefly. For simplification, Jordan spelled it out again very clearly. You can diagnose someone in 1 visit. And this is something that's going to take some time and working with legislative bodies and communities, but again, making sure that people are not stigmatized just for having been exposed to one of these viruses. And frankly, while the stigma should not exist after someone has been cured of hepatitis C, it shouldn't exist whether that person is still living with it anyway. So stigma remains a huge issue that we have to continue to address. And we've seen some really incredible strides in reduction of HIV stigma. So there are good models out there. Integration, of course, we aim at my office in Seattle to bring everything that our clients need to them in one place. And we've identified people living with hepatitis C who we've been working with for 2 or 3 years who have not been interested in getting their hepatitis C treated yet, or not able to. And in the meantime, we're working with them on getting Medicaid-assisted therapy. We started a buprenorphine program earlier this year, a collaboration with a federally qualified health clinic and a big behavioral health group. And so we have people come to our office. We have a syringe service program. We now offer medication-assisted therapy. And we have, as I mentioned before, this wraparound services case management team that includes peers that are built into it. And again, we've been in the community for more than 20 years, and so we have this established trust. And most of the people that we work with don't want to step foot in a medical clinic or an emergency room because of the way they have been treated, just because they use drugs or just because they're homeless in those settings. So this is that critically important kind of third space where we're bringing services, as many as possible, to our clients in one place at one time. Decentralization, again, critically important. I think in any part of the globe, we need this to be an effort that everyone who has a touch point for these people who are potentially at risk for hepatitis B or hepatitis C is involved. And then the part where the specialists will certainly agree is that there is a very, very important role still for them. Complex cases, people with cirrhosis, people with comorbidities still need to be seen by the specialists. And so now I'll hurry through this last bit, but we were very fortunate after a lot of hard work to get our governor, and there's a bit of a debate whether Governor Cuomo in New York or our governor Inslee in Washington State was the first to announce a plan to eliminate hepatitis C. But this happened just over a year ago. And looking at the WHO targets for elimination, he committed to eliminating hepatitis C in Washington State by 2030. And like a lot of overnight successes, it was decades in the making. So this didn't just happen over the course of the previous year. We've been working on the ground in Washington State really since the organization that I work for was started in 1993. I've been there for a little bit shorter time, since 2001, but from the beginning, when this group of hepatitis C patients came together in '93 to really advocate for themselves and, very importantly, to find out more about this new disease that was still very unknown, we've had some successes over the years. And it was this group of people, and I love this shot, the group that I work for was started by a bunch of, activists in their 50s who kind of lived through the 60s and 70s. And this is 20 years ago in our state capitol, and they were out there with their poster boards demanding action for the silent epidemic years before most people even had hepatitis C on their radar. So it is something that does often take time. I think we do have this groundswell, this momentum. So in many places, you don't need that 20-year kind of push to get to an elimination plan. But I do want to acknowledge and recognize the people, some of whom are no longer with us, and these are almost all patients, and several of whom sadly did not live long enough to take advantage of these new amazing curative therapies. And so this is the group that came together in Washington State to come up with a hepatitis C elimination plan. And I'm just going to touch on the involvement of patients in the affected community in developing this plan, because it has been crucial to getting to where we need to be to have this plan really informed by the voice of the patient and the affected communities. So I will jump ahead a little bit just to say that we have active drug users on the coordinating committee. We have people who have been recently incarcerated, no currently incarcerated, unfortunately. And this has been a process that took a relatively short 6 or 7 months, and we have, as of July 26th of this year, an official elimination plan for the state of Washington. 15 goals in 3 categories: clinical strategies, strategic information, and community-based response. And each of those was a specific work group that was informed and populated by people living with hepatitis C or those as part of the affected communities. And my time is up, but I just wanted to really emphasize that not only is it the right thing to do to involve patients and the affected community in any of the discussions that we have around the response to hepatitis B and hepatitis C, not just elimination efforts, but setting up state, local, government, national plans. It's also a best practice, because we know when patients and community are involved, the outcome is much better. We know that in countries where civil society is engaged, they're twice as likely to have national plans, twice as likely to have national plans that are funded. So I'll leave you with that. Don't forget the patient, and remember to keep community involved. Thank you.